diseases. It is caused by a group of bacteria that in science we call them Mycobacterium tuberculosis complex. This bacteria or germ normally affects the lungs. We pass on from one person to the other by coughing, talking, singing, even spitting. In fact, that is one way. The way some people spit out, that is one way that we are able to spread the germs. The germs normally affect the lungs, but in advanced stages, it can affect every part of the body. Most of the people who get tuberculosis, how you can know that this one, or I may have TB, is that you may be coughing quite more than a week. You may be coughing, and so most of the time that cough will produce what we call sputum, or it is productive. So even if you are coughing for a long time and you're not producing sputum, go to hospital for checkup. Normally, people who have tuberculosis, when you sleep in the night, you sweat profusely. I know it is hot, we do sweat, but then those who have TB, the sweat is heavy, and even if you are sleeping under the fan, you sweat a lot. You realize that you feel generally sick. What's general malaise? You feel very weak. Breathing sometimes is difficult. Sometimes when you cough, it brings out the phlegm, has blood in it. And then sometimes climbing, you feel that you are finding it difficult to breathe. If you have any of these symptoms, then you may have to go to hospital to check whether you have TB. And the good news is that when you go to hospital to check if you have TB, you don't pay for the laboratory test. All that you need is to go to the hospital. The good also news is that you don't pay for the medication. And now there are very good medications that if you follow up the instructions by the nurses and the doctors, you can be cured of TB. There are a lot of challenges with TB, and Noguchi is working very well, has been working with the National TB Control and the World Health Organization, the General Health Fraternity, to improve our understanding of the TB diseases. We started working with the National TB Control about 20 years ago, with 1999, so it's about 26 years ago when we started as an institute to support Ghana's fight against TB. When we started, one of the key problems is that TB requires a good laboratory support for case detection and also to manage the cases. And we found out that Ghana didn't have a very good laboratory system. So we worked with the National TB Control Program. We did a tour of the whole country, what we call situational analysis. We identified the gaps, we developed manuals, and we trained health personnel. After our laboratory system was well put in place, then we began key research studies. One of the key research that we did was to look at areas where there's massive transmission of TB. That requires, if we remember during COVID, we heard about whole genome sequencing, we heard about variants, and that is the work that we have done, started doing that before COVID came. And we worked with the Kolebu Teaching Hospital, Ghana Health Service, and one of the key work is that we did a population-based study to look at, especially Accra, who are the people who are at risk of TB, areas of intense transmission of TB using whole genome sequencing, what we call genomic epidemiology. Our work produced very good results. Based on our work, we were able to support the National Control Program to know areas, especially in Accra, that we have intense transmission, so that we do community engagement, active case search to improve case detection. Other work that we are doing that's also a challenge with TB is drug resistance. In fact, in the people who have drug resistance, as I did it with the introduction, there is good medication, but there are some people when they get TB, they don't take the medication according to the instructions that they are given. And this made the bacteria to change. And when they change, what we call in science mutate, they change their DNA. It leads to them not responding to the medication that is given. And so one of the key work that we've done is to look at the intensity of drug resistance in Ghana, look at the DNA, to look at some of the mutations or the changes in the DNA. This is very, very, very important because now we are improving diagnostics for TB. And when you go to the hospital, we use the Gene Expert. The Gene Expert is based on whole genome sequencing and analysis that we've done that allow us to understand the mutations for the resistance, and that is what we are using for the diagnostics. So one of the work that we are doing is to continually look for the changes in the bacteria or the mutations that are leading to drug resistance. And when we do that, we contribute to what we call the WHO mutation album. So this is one work that we are doing. And we also do that because it guides the National TB Control Program to see whether they are effective in terms of the control activities. For us as scientists, one of the key ways that we think we are contributing is that TB in humans, everybody, the name is tuberculosis. So in the science, the bacteria that causes tuberculosis is called, in humans, it's called Mycobacterium tuberculosis. But people in West Africa alone, and we don't fully understand, there's another bacteria that is called Mycobacterium africanum. And that also causes TB only in West Africa and some people in Central Africa. And because TB is a global problem and there are a lot of work that is going on, sometimes the Africanum is not much studied. And so we are continually doing intense scientific work to understand Mycobacterium africanum so that any development like vaccine that will be developed, understanding of Mycobacterium africanum will not be neglected. It will not be forgotten. And this is one of the work that we are doing it. And we have a group of scientists in West Africa. We are called WANETAM, or West African Network of Excellence for TB, AIDS, and malaria. And we are intensely working on Mycobacterium africanum so that we can continually provide information data to support the fight against TB caused by Mycobacterium africanum. There are a lot of other studies. TB also one of the, apart from human beings, TB can also affect other mammals like cattle, goats, and sheep and others. And so those bacteria that affect the cattle, we call it Mycobacteria bovis, that is bovine TB. And they can also sometimes infect human beings. And so we are working with also veterinary services, and one of the things is to survey the abattoirs and also look at some of the cattle that they slaughter to see whether they contain Mycobacterium bovis, and to look at whether the bovis also being transmitted to humans. So these are some of the studies that we are doing. I think there are so much better. One of the key challenges is that TB, in fact, it kills more humans than any other infectious diseases. I think here we always talk about malaria, we are talking about typhoid, we are talking about HIV. They are also equally important, but we don't talk much about TB. But TB kills humans more than any other communicable diseases. In fact, every year, I'm sure the NTP has told you, we have more than 10 million people get sick of TB and close to 2 million people die of TB. Every second someone is dying of TB. And we require a lot of investment because the fight against TB, we need to work such that most of the tools are delivered as free service because most of the affected are poor and they cannot buy the medication. You have to take medication at least for 6 months. At least for 6 months daily. And so we require a lot of investment. And so this year the theme is that if we want to end or stop TB, then we need to commit to research funding, commit to community engagement, commit to providing money for health system, commit to finding money to buy the medication, all the diagnostics so it's commit, invest, and deliver appropriate interventions to stop TB. This is what we are calling the world. And TB is everywhere. We sit in Trotro, we are in the churches as we are singing. TB affects children, it affects the young, it affects the elderly. So what we are saying is that CID, commit, invest, and deliver appropriate intervention. Now we are not anywhere near eradication. We are controlling, but we want to stop. And that is why we have the roadmap we have the 2030, 2035, the NTB strategy. But we are some countries in the north, that's the developed countries, are sort of reaching the goals. For the world, one of the regions that are really, even though some achievement has been done, but we are still behind, is West Africa. And so we need to invest such that we can reduce the deaths associated with TB by at least 90%.
Noguchi Memorial Institute for Medical Research. These are high containment laboratory. This is where we work on tuberculosis. So we'll give you a tour of the lab. It is highly controlled. Not everybody is allowed inside the lab. So it's only those that have been trained and certified that can work in this lab. So kindly.
Protect ourselves since we work on positive samples, positive TB samples only.
This is the biosafety level 3 lab. This is where we work on TB positive cases, samples. I'm sure from your talk with Prof, she told you about the different projects that we are working on. This is where all the samples come from all over Ghana. And this is where we work on the samples.
So as you've entered here with one pair of gloves, ideally you have to also wear a double pair inside the lab before you can touch anything in the lab. So go ahead, wear the glove before I proceed to show you around the lab. I'm in my double pair of gloves and it means I'm ready to work. But before I work the rule that you are supposed to also log into this book to show that you came into this lab and record the status of the lab as you came to meet it, both the room temperature, the pressures. This room has a negative 50 pressure, and you have to record it and make sure it records the appropriate pressure before you can work in it. If it's beyond or below the appropriate pressure, you can't work in it. So record all those things before you start working. And for TB diagnosis, this is the flow of what we do. Everything is captured in this flow. For one, we receive our samples through something we call a pass box. And whatever comes here does not leave the same. It has to be sterilized before it leaves. So the pass box, we receive the pass box. I'll show you the pass box in a second. Then it comes into the hood. That's the biosafety cabinet where our colleague is working currently. And that's where the box that contains the sample is opened and inspected. And if the sample is a quality sample, we accept it. Does not meet our acceptance criteria, we reject it and we ask the lab to use a better quality sample so I can provide accurate diagnosis. So here we use the Gene Expert machine. We have two of the models, the one that has 4 models. two of them. So it's a cartridge-based machine. In this expert machine was also for COVID-19 diagnosis. It's also used for diagnosing other diseases, HIV, hepatitis, other viruses. But for years, we mainly used it for TB diagnosis. So once we get a sample in there, we prepare it according to a protocol over here. The protocol comes from the manufacturer. Okay, we have reagents that we add to the sample. We prepare it in 15 to 30 minutes. Then we bring it into this machine. We load it into the machine. Then we run it. It takes about 1 hour to 1.5 hours to get a result. So in 1.5 hours, you're able to tell if something is positive for TB or
give the, yes. So as he talked about, we give the bacteria special medium to grow. Just as you need nutrients to grow, the bacteria also need some nutrients to grow. So these are the nutrients that we give the bacteria, and then we put the sputum, what is produced by the patient. We process it and then put it on this media, and as he said, for about 4 weeks we observe. If there's growth on it, you see clear something is growing on it, and that is what we take for the further analysis. So this is one of the incubators. Yeah, this is one of the incubators that we used, and as he said, there are about 2 or 3 different incubators that are being used in this lab.
we use this other machine, we call it midget, the microbacterial growth indicator tube. That is a liquid culture. What we took you through earlier on was the solid culture. This one is a liquid culture. This takes about 1 week to get results, and we follow on to, transfer the results to the clinicians for management of the cases. So this machine is midget, and that takes about 1 week. It's a liquid culture system. And this one is the solid culture system, and that takes about 4 weeks to 6 weeks. Of course, you get better yield and growth on this solid culture compared to the liquid culture. They all have their pros and cons. So basically, that's it, and that's our biosafety cabinet. There are 2 of them. That means that we can work simultaneously if we have a lot of samples to work on. And for us, like we said, we also focus on research because we're a research institute. So once you get any isolates from this cultures, whether the liquid or the solid, we move on to process them, to store them, and archive them for future research. So we have a minus 80 degrees Celsius. We don't keep the isolates in 5 degrees Celsius, no, because they will also die. You are supposed to preserve them, cryopreserve them. So in the freezer. Not the normal freezers we use in our homes. The normal freezers in our homes are about minus 20. But these ones, we go beyond the minus 20 to minus 80. You can see it's freezing cold. We can keep them there for up to 10 years or beyond, and they'll still be alive. So anytime, if there's any vaccine clinical trial, any new diagnosis that we want to test, we can recover those isolates and test the efficacy on the new tools that have been developed. So that's our 80 freezer. We also have minus 20, of course, for short-term storage, not for long-term storage. Yeah. So this is how a typical minus 80 freezer looks like. We have canisters and we have trays. So each of these is a tray that contains boxes, that contains valves, that contains the microorganism. And not everyone has access to this. So every position here is archived, is electronically controlled. We know where every valve is stored in this archives. Beyond this, you have a biobank also not in this facility, but outside.
sterilize it. We use a special machine called the autoclave to sterilize everything that is worked on here before we take it out. So we have one here that is for what is inside here. We also have one outside for the lab coats that we wear. These lab coats are worn, it's disposable. So once I worn it, it has to be sterilized and then thrown away. And the gloves as well. Box is meant for items that are coming into this lab. When you are entering this lab, you enter with empty hands. So if you have something you are going to work on, like he talked about samples, or you have some consumables or reagents, you put everything inside here. You can open from the outside. You put everything in here. It is sterilized by UV. You come in here, you don your lab coats, come in here, open it and take it out. The same way everything that is sterilized you are taking outside, you put it in here. It is also sterilized again with the UV. When you get out, you can open the door and then take it out again.
A research fellow here at the Noguchi Memorial Institute for Medical Research. And at Noguchi, I'm in the bachelor department and I man the Biosafety Level 3 lab, also known as the PA3 lab. And I'll talk to you later about TB, the risks involved in TB. And basically, there are some risk groups. I mean, we all know that everybody, whether rich or poor, whether tall or short, whether male or female, is liable to getting infected by the organism that causes TB, which is Mycobacterium tuberculosis complex. So everybody can be infected by it, but not everybody will develop the disease. And in fact, I mean, if you take a survey, within every 3 people, at least 1 or 2 in Ghana has the infection. But it doesn't mean these 1 or 2 people develop the disease. They may live with the bacteria for their entire life and die with it without showing the disease. But just a few people, about 5 to 10% of these people who get infected, actually live to develop the full-blown disease, which we call TB. And mostly they do that because they are probably the vulnerable groups. We talk about HIV. If you have HIV co-infection, your immune system is suppressed, so they're not able to keep the bacteria in check, and therefore they're able to fight the immune system and become a full-blown disease. Also, I mean, children also a vulnerable group. Even though we have BCG vaccine at birth, it does not, I mean, protect us lifelong. So children also get TB, and we also talk about now there's increasing diabetes. I mean, if you have diabetes, you are likely that you can also, I mean, activate that I mean infection in you. So these 3 categories. We also have malnutrition. I mean, without your a good nutrition, I mean, you cannot build up your good immune system to be able to fight the disease. So basically, once you get infected, it's your immune system that keeps it at check and keeps them till you die. But if your immune system is weak, then they overpower your immune system, which is the soldiers of your body, and then once they've overcome it, then they'll spread and cause a disease that will, I mean, manifest in the coughing, in the night sweats, in the weight loss, and all the symptoms that accompanies TB. So aside these groups, also, I mean, living in overcrowded areas, I mean, it's also a risk factor for getting TB. So if you live in a room, for instance, with 4 or 5 people, and one person coughs, then the chance that the other people will pick it up is very high because it's spread by aerosols. When someone coughs, the bacteria is just spreading the air. Once you're in the vicinity and you inhale it, you get infected. And if your immune system is not good, they will go and become a full-blown disease. So basically, these are the risk groups, and we should be careful. Once see someone coughing for more than 1 week, 2 weeks, please advise the person to seek medical attention. The diagnosis is free, the treatment is also free, and you will certainly be cured.
Caused by a bacteria that is aerosol. One thing we noticed during our research is that there's a lot of stigma on TB. So you have people coming all the way from the north to just come and seek treatment in Accra. For us, what we decided to do was to do community outreaches. So we went into the community to try and educate them on TB. That's where we saw that the stigma was really big. People have TB, but they are afraid to talk about it because they think it's caused by witchcraft. They think it's caused by a curse. They think that they didn't do some donation at church. They think that somebody looked at them with some evil eyes. That's why they got TB. But through our education, we've been able to get some members of the community to attend the chest clinic at Kolebu Teaching Hospital. We do all this hand in hand with the National Tuberculosis Program and then the chest clinic of Kolebu Teaching Hospital. We've screened most of the communities around Kolebu. We've gone to Kolegono, Bukom, Dansuman, Choko, Lefe, screened them. We also are very grateful to the chiefs and queen mothers of these areas because they have become fully involved, helping us to get the community members to come to the hospital. We realize that most people, just like ordinary people, do not like going to the hospital. So we would bring the hospital to your doorstep. We will come door to door, educate them on TB, set up a medical table, bring a mobile x-ray van, which is provided by the National Tuberculosis Program, screen people on site, and then if they pass a certain limit of the x-ray, get sputum, come and do the diagnosis at Noguchi, send the report to the National Tuberculosis Program and the chest clinic, and then go and pick the community members to the hospital and get them treated. Prof talked about treatment. Yes, treatment is for 6 months. What we realized that after 2 months, taking the cocktail of antibiotics that my colleague talked about, most people feel better, so they stop taking it. That is where the resistance starts coming in, the antibiotic resistance starts coming in. So one of the projects that we are doing, that we are screening people after 2 months, after 4 months, after 6 months, doing screening. And once we realize that you have absconded, as we say, we go back into the community to bring them back, encourage them to come back. I'm sure when you went into the community, you found TB champions. We have a lot of TB champions around, and we work through them to educate people that TB is not caused by a curse. It's not caused by the fact that you did not go and do a tithe at church, or your pastor saw your grandmother giving you TB in your dream. These are some of the things we get from the community when we interview them. So the TB champions help us with education, and as my brother gave you some of the leaflets, we translated some of the leaflets into the local languages so that they could understand what it means. And we've used this whole week to also educate them that TB is treatable. Treatment is free, absolutely free. Just walk into any hospital. If you've coughed for more than 2 weeks, walk into any hospital and you'll be given free treatment. Ghana has now taken childhood TB as one of its main priorities. One of the indicators of ongoing transmission of TB is for children to be getting TB, because children are normally regarded as reservoirs of TB. So most parents, once the child starts coughing, give them antibiotics. But we are also advising parents that once your child starts coughing, after 2 weeks, nothing is happening, please take the child to the clinic. It's normally we do general antibiotics because the child is coughing, maybe the child has temperature. But once the child is diagnosed properly, the proper treatment is given to the child. Most children cannot produce sputum. So WHO has now come out with a diagnostic tool where we use stool to also diagnose the TB in children. And that is quicker, and that is easier and safer, and we're able to get the results in good time to help treat the children. TB has been with us since the olden days. It's even in the Bible. If you read Deuteronomy, TB is there. So since the Bible was even written, TB is there. It's a disease of ancient days. TB is aerosol. My professor rightly said, other diseases you go and buy it. Typhoid you would buy it. It's because of that. Cholera because of that. Malaria is because of mosquitoes. But TB is aerosol. You need to breathe to survive. TB is in the air. My advice to the general public is that treatment is free. Once you get TB, do not be shy. Please walk into any public hospital and you would be treated. It is free. You call for 2 weeks. After 2 weeks, please go to the hospital and you will be treated. Do not be shy and be afraid that you will die. It is free. We have the drugs available.